A 62-year-old woman presents to your GP clinic with sudden, short-lived episodes of spinning vertigo whenever she changes head position, particularly when turning in bed. Each episode lasts only seconds and is accompanied by nausea, with complete resolution between episodes. She denies hearing loss or tinnitus. You suspect BPPV, Benign Paroxysmal Positional Vertigo. But what's actually happening in the ear? What's the key bedside test? And what's the first-line treatment in the UK according to NICE guidelines? By the end of this video, you'll be able to diagnose BPPV confidently and manage it in a UKMLA ready way. So let's break down the definition. Benign paroxysmal positional vertigo, or BPPV, causes brief, repeated episodes of vertigo that are triggered by changes in head position. It's the most common cause of peripheral vertigo. Benign means it isn't dangerous. Paroxysmal refers to the sudden bursts. Positional tells you that it's triggered by movement. And vertigo means a true spinning sensation, not just lightheadedness. BPPV becomes more common with age. The peak incidence is around 60 to 70, and it's more common in women, roughly 3 to 1. There are a few common associations and risk factors that you should remember. BPPV is much more common in older adults because age-related degeneration makes the otoconia more likely to dislodge. It can also follow head trauma, which is why we sometimes call it secondary BPPV. Some patients develop symptoms after a recent vestibular illness, such as vestibular neuronitis or labyrinthitis. And finally, recurrence is common. Many patients describe repeated episodes over months or even years. To understand BPPV, you first need a quick overview of ear anatomy, in particular the inner ear. The inner ear has two main jobs, hearing and balance. For balance, it's made up of the vestibular system, which includes the three semicircular canals, the utricle and saccule, together called the otolith organs. The semicircular canals are arranged at right angles to each other, so they can detect rotation of the head in all directions. They're filled with fluid, and when your head turns, that fluid moves, bending hair cells. This tells your brain how fast and in which direction your head is rotating. Next is the utricle, which sits at the base of the semicircular canals. The utricle contains tiny calcium carbonate crystals called otoconia. These crystals normally help you detect linear movement and head tilt, like accelerating forward or tilting your head up and down. In BPPV, some of these otoconia become dislodged from the utricle. They then fall into one of the semicircular canals, most commonly the posterior canal. When the head changes position, these loose crystals move within the canal, pushing the fluid more than they should. This sends false signals to the brain, making it think the head is spinning, even though it isn't. That mismatch between what the inner ear senses and what the eye sees is what causes the brief, intense vertigo of BPPV. BPPV has a very characteristic presentation. Patients describe vertigo that's triggered by head movements, things like rolling over in bed, looking up, or bending down. The key point is that the episodes are brief. Each burst of vertigo usually lasts just a few seconds, and almost always less than a minute. Nausea is common, and some patients may even vomit during an episode. Crucially, there's no hearing loss and no tinnitus, and that's a really important discriminator from other inner ear causes of vertigo. Between attacks, patients might feel slightly off balance or unsteady, but they're not continuously spinning. BPPV is mainly a clinical bedside diagnosis. You don't need routine blood tests or any scans. The key test is the Dix-Hallpike maneuver, especially for posterior canal BPPV. For the Dix-Hallpike maneuver, you sit the patient up, turn their head 45 degrees to one side, lie them back quickly with the head extended slightly off the couch, and watch the eyes and ask about vertigo for 30 seconds. A positive test reproduces the vertigo and produces rotatory nystagmus, often with a brief delay. As a safety note, be cautious with patients with significant neck or back disease. If the story screams BPPV but Dix-Hallpike maneuver is negative, consider horizontal canal BPPV. That's where the supine roll test can help. Before you label this as BPPV, you always need to think about the key differentials. First, Meniere's disease. This causes vertigo plus hearing loss and tinnitus, or ringing in the ears. There can also be a feeling of oral fullness. Next, vestibular neuronitis. Here, the vertigo is continuous and severe, often lasting days, but there's no hearing loss. Then there's labyrinthitis. This looks similar to neuronitis, but with hearing loss and tinnitus as well. And finally, you must always rule out central causes, like stroke or TIA. Red flags you should always ask for include any new focal neurological deficit, or if the patient is unable to walk unaided, any new severe headache or collapse, or marked new hearing loss with any other concerning features. If red flag symptoms are present, don't label it as BPPV. These cases need urgent escalation. In terms of management, you should start with reassurance. BPPV is common, not a brain tumor, and it does settle, but it will increase fall risk, especially in older adults. In UK practice, first-line treatment is a canalith repositioning procedure, most commonly the Epley maneuver. It works by guiding the loose crystals out of the semicircular canal back into the utricle. Success is high, often around 80% with one attempt, and even higher with repeats. If symptoms recur or you can't access a clinician immediately, teach Brandt-Daroff exercises at home for vestibular rehabilitation. Patients are often prescribed things like beta-histine, but for true BPPV, it's usually of limited value because the problem is the crystals, not the inflammation. If someone is extremely nauseous, short-term symptomatic help can be used, but the real fix is still repositioning. You should safety net by advising patients to reduce fall risk. They should sit on the edge of the bed before standing and avoid any sudden head movements if they're currently asymptomatic. They should also come back if symptoms change character or become continuous. Now, BPPV is benign, so it's not dangerous in itself, but it's definitely not trivial. For many patients, symptoms will settle spontaneously over weeks to months. That said, recurrence is common, and a lot of people will experience repeat episodes over the following years. The main complication we worry about is falls, especially in older adults, where even brief vertigo can be risky. And if symptoms keep coming back, patients may start to avoid certain movements, leading to anxiety, reduced confidence, and a real drop in quality of life. So to recap, BPPV, or Benign Paroxysmal Positional Vertigo, is a brief positional vertigo caused by displaced otoconia in the semicircular canals. It is diagnosed with the Dix-Hallpike maneuver, where you recreate symptoms of vertigo and rotatory nystagmus, and it is treated first line with the Epley maneuver. No hearing symptoms is an important clue, and if red flags are present, you must consider central causes. Thank you very much for listening, and if this helped with your UKMLA revision, make sure to hit the like and subscribe button, and comment which ENT topic you'd like to hear about next.